the second in some back-to-back talks related to drugs and devices. Last month when I was here, we talked primarily about new drugs that have recently become available for inhalation. Today we'll talk more about new devices, although it's hard to separate drugs from devices. And there I also need to say that part of the lecture is new and part of it is old. So we'll review some things about some existing technology. So our objectives are to compare jet nebulizers, ultrasonic nebulizers, and mesh nebulizers, to state the nebulizers used for specific formulations, because increasingly, as new drugs are being released and cleared by the FDA, they're cleared to be used with a specific device, and we'll talk about some of those. To compare pressurized meter dose inhalers with dry powder inhalers, and to discuss the important factors in the selection of a specific inhaler device for an individual patient. So this is what we talked about primarily the last time that I was here, were drugs. So bronchodilators, beta agonists, muscarinic antagonists, which we sometimes call anticholinergic agents. We talked about how these are available as short-acting and long-acting formulations. We talked about inhaled corticosteroids, mucokinetic agents, antimicrobials. We just touched a little bit on inhaled vasodilators, dyspnea modifiers, so narcotics, opioids can be inhaled in the treatment of dyspnea, as can Lasix be inhaled for the treatment of dyspnea. And then there are anticoagulants like heparin that can be inhaled, antifibrinolytics like tranexamic acid, and thrombolytics such as TPA that can be inhaled for very specific indications. And also insulin can be inhaled. So I guess we could say as respiratory therapists anymore, we need to think of ourselves not only as far as what happens in the lungs, but there are inhaled agents which deal with hematology. They are inhaled agents which deal with endocrinology and so forth. Those parts of our physiology course that maybe we didn't pay as much attention to as we should have. These are the GINA guidelines for the treatment of asthma, and I had gone through this last time that I was here, and just as kind of a bit of a recap for treatment of asthma. We should think of inhaled corticosteroids and long-acting beta agonists and combinations of those for control, and short-acting beta agonists for relief. And then these are the GOLD guidelines for COPD management that I had also shown last time that I was here, which points out that we should think about long-acting muscarinic antagonists and long-acting beta agonists and combinations for control. And there is actually now one formulation that is available for severe COPD, which is a combination of long-acting muscarinic antagonist, long-acting beta agonist, and inhaled corticosteroids. So that's triple therapy, which is used for severe COPD. And then, different than asthma management for COPD, we think about either a short-acting muscarinic antagonist or short-acting beta agonist or combination for relief. So often for COPD, the reliever drug is a combination of short-acting muscarinic antagonist, short-acting beta agonist, so that's Atrovent and albuterol, which is Compavent or Duonet. So that's just a little bit of a recap from from some important things that we talked about last time that I was here. So today we're going to talk about aerosol generators. We're going to need to talk about nebulizers, which might be a little bit more complicated than we appreciate in our practice sometimes. So these can be either jet nebulizers, ultrasonic nebulizers, or mesh nebulizers. I know sometimes we think of ultrasonic nebulizers as devices of the past, but now there are actually several devices that are very portable that patients can use to administer inhaled bronchodilators, and we'll touch on that in just a little bit. The Respimat soft mist inhaler, or the SMI, became available just within the last 10 years. And then Pressurized meter dose inhalers have been around for a long time, dating back 50 years, which can be used with spacers or valve holding chambers. So we'll address the question, does every patient need a spacer or a valve holding chamber? And I'll give you my take on that. And then we'll talk about dry powder inhalers, of which there has been an explosion of devices just over the last 5 to 10 years. The reason for that being that when pressurized meter dose inhalers needed to go from a CFC to an HFA propellant, a lot of manufacturers just stopped making meter dose inhalers and switched to dry powder inhalers. So there are a lot of new formulations now that are becoming commercially available only as dry powder inhalers. So here is our friend the jet nebulizer that all of us, I'm sure, should be very familiar with. So these rely on a compressed gas source. The compressed gas source draws a liquid from a reservoir and blasts it against a baffle to produce an aerosol, and then the patient inhales that aerosol. But for many, not all, nebulizers, the aerosol is produced not only during the time that the patient's inhaling, but is also produced while the patient's exhaling. And because the expiratory phase is much longer than the inspiratory phase, the nebulizer tends to be a very inefficient aerosol delivery device. There's probably more aerosol that gets blown into the face of the caregiver, you and me, than is actually inhaled by the patient. Moreover, with a jet nebulizer, there is a certain dead volume, which is the volume of solution which remains in the nebulizer cup after the nebulizer stops producing an aerosol. And that dead volume is typically about a milliliter. So you can imagine if you only put 2 milliliters of solution into the nebulizer, half of it never gets aerosolized because it's the dead volume of the nebulizer. So think about that when you think about putting 2.5 milliliters from a unit dose vial of albuterol into the nebulizer. Half of that gets shaken out at the end of the treatment or gets thrown away with the nebulizer and never gets aerosolized. New devices such as the mesh nebulizer get around that. So bottom line is that only about 10 to 20% of what we put into the jet nebulizer actually ends up being deposited into the lungs, because a lot of it gets wasted during exhalation, is trapped in the nebulizer dead volume. It also turns out that there is a lot of variability among brands of nebulizers that are commercially available. This is a study that we did on the other side of the wall from where Purvis is sitting now. When we were running, for a number of years, we ran an aerosol lab and did a lot of studies on aerosols. And this is one of the first ones we did about 25 years ago. This was published back in 1996. The data, I think, is still relevant today. Others have tried to reproduce this study and have found similar results. And that is, if you look at the amount of drug that's available for inhalation, here we studied, you can count them, I think there are 17 different nebulizers. And they vary all over the place. So you can imagine, for example, if this is the nebulizer we were using in the hospital, and then we switched to this one because it was cheaper, we would cut the amount of drug that is delivered to the patient by more than half. Now maybe it doesn't matter too much for bronchodilators, but for other types of drugs, maybe that is important. I'll also point out that some of my co-authors are still around. One of them is still in the room. This was when we were accused of being very nebulous because we were cranking out all these nebulizer studies. So then if we think about the driving gas flow and the fill volume for a traditional jet nebulizer, we can conclude that increasing the flow increases the nebulizer output. So there's a greater output if we increase the flow. Increasing the flow also decreases the particle size, so that might be good. And it decreases the nebulization time, which patients and caregivers appreciate. increasing the fill volume increases the nebulizer output, but also increases the nebulization time. So there's that trade-off. So generally it's recommended, and this comes from actually work that we did here in our aerosol lab years ago. Generally it's recommended that we use a fill volume of 4 to 5 milliliters for a jet nebulizer and a flow of about 6 to 8 liters per minute. So what's the problem with that? Well, the problem with that is that, and I mentioned this earlier, a lot of the unit dose vials for albuterol are less than 4 milliliters. So I think they're typically 2.5 milliliters. So then to optimize the output of the nebulizer, we either need to top it off with saline, that's one option, or we could double the dose and put 2 ampules into the nebulizer. But at 2.5 milliliters of solution in the nebulizer, 1 milliliter or so of that's dead volume, so half of the drug gets wasted right off of the top because it never gets generated into an aerosol. Now there have been other companies that have paid attention to this, such as, what's the volume of an ampule of Toby? I think it's 5 milliliters, I believe. So then that will optimize the output of the jet nebulizer, specifically the Part2 nebulizer that we use for that. So many unit doses have suboptimal volume, although some of them have an optimal volume. It's also important to appreciate, and this becomes particularly important for patients at home, is that if a nebulizer compressor combination is used, sometimes the compressors don't work very well. So that the compressor may not generate the 6 to 8 liters per minute, and in fact the performance of the compressor may deteriorate over time, particularly if the patient doesn't take very good care of it, doesn't replace filters and so forth.
And sometimes though, when you go up in a flow, it just pops off all the time. If I ever went to 8 liters on a regular neb, it constantly pops off.
Oh, okay.
Yeah. I'm just wondering, has anybody ever had that experience? Yeah. The increased flow. If you're over 5, you get to 6. If you get past 6, it constantly pops off.
So that's then a problem with whatever the nebulizers are that we're using.
You put them on 8 and they stay. Not a peri-neb, just a regular neb.
Oh, peri-nebs.
Regular nebs.
Peri-nebs seem to stay on.
Yeah, right.
But Patty's right. Anything much over 6 liters, you have run risk of it.
Yeah, so I guess then the point is that maybe the nebulizers that are supplied here, maybe the nebulizers, not only is there an issue with unit dose perhaps being suboptimal, but the nebulizer may not accommodate the optimal flow either. Now, over the years, there have been a number of designs that have become commercially available in an attempt to improve jet nebulizer performance. So one design is the Circulaire, which I don't think has ever become very popular, but it is still commercially available, that uses a storage bag so that during exhalation, the aerosol, rather than blowing out into the room, goes into this bag, and then the patient inhales it on the subsequent inhalation. So that's a clever idea. I think it adds a fair amount of expense, and probably for that reason it's never become very fashionable. There are breath-enhanced nebulizers, which you know as the Part2 nebulizer. This is the non-disposable design. The disposable design is the one I think you probably have used more so in the hospital. These are breath-enhanced because during inspiration, during inhalation, the patient breathes through the nebulizer. So this has a mainstream design so that the patient breathes in through the nebulizer, which boosts the output during inhalation, and then there is this opening on the disposable, or the valve on the non-disposable, that opens during exhalation, so the patient does not exhale back into the medication cup and blow the aerosol back out into the room. So the aerosol accumulates in the nebulizer during exhalation, and then when the patient breathes in, it enhances the output because of the mainstream device. And it's because of this mainstream breath-enhanced function of the PARI nebulizer, that you can't just use a T-piece and hook it into a ventilator circuit, because that defeats the whole purpose of breathing through the nebulizer and boosting the output of the nebulizer.
Dean, can I add something there too? So a lot of the younger kids, they're coming into having a face mask with corrugated tubing.
Yeah.
It wouldn't work effectively either.
Correct.
Yeah, we
Right.
stamp that out.
Mm-hmm.
Nope, it would not, unless now PARI does make a specific mask to go with the PARI nebulizer, but the mask has the one-way valve
Right.
in the mask rather than in the mouthpiece. But a jury-rigged aerosol mask and corrugated tubing is going to defeat the whole purpose of the PARI nebulizer. And then there are breath-actuated nebulizers, the Aero Eclipse, and as the name implies, when the patient breathes in, it actuates the nebulizer, produces the aerosol. Then during exhalation, nebulization stops. And these have become quite popular at some places around the country. You're shaking your head like you have experience with the Aero Eclipse. And there, I'll ask you, what solution did you put into the nebulizer? Because in some places they put in straight albuterol with breath enhanced.
So we use Duomems.
Just a regular nebulizer. One of the issues is by it being breath enhanced, it can take longer to administer the treatment because you're not wasting the drug during exhalation.
Question. When you put it on a continuous mode, it does.
Yeah, so you can put it in a continuous mode. How do you do that since you brought it up?
You turn the top, there's a.
This button up here, right?
Yes.
So and I'm assuming you did not use it. You use it as breath actuated, not as a
So we
continuous.
would, that was our primary neb for a while, so if people needed a mask, we would have an elbow and put it in continuous
Yeah,
and
yeah.
let them use the mask.
Yeah, so as both of you point out, you can override the breath actuated part of the nebulizer so that it's no longer breath actuated, and it works just like any other nebulizer. And I don't know why you would buy an expensive nebulizer to override what is the primary feature of that nebulizer. So I already pointed out the issue of nebulizer compressor combinations. So many times for home use, if the patient uses a nebulizer, they will use a nebulizer that is paired with a specific compressor. So you go to CVS or Rite Aid or whatever, and in the box, you get the nebulizer and you get the compressor combination. There are other possibilities where you would just get the compressor and you could use it with any old nebulizer that you want to. I don't know what they supply here anymore for compressors
For home care or in hospital?
in hospital.
It's the pulmonary still.
Oh, okay.
Yeah, that's.
Next to the desk lamp. I was looking at the desk lamp.
This is what they get to go home with, or this is what they get for in-house?
When they go home.
Okay, so that is this one, right?
Yeah.
Or
Yeah.
it's whatever the care has in the back.
So one of the things that maybe we should question is when they go home with that, do they get the nebulizer that comes with it?
Yes.
Hopefully they do.
They get one or one in the box.
Good. Because there have been several studies we published in respiratory care just over the last 5 years that show that if you mix up the nebulizer and the compressor, that can affect the output of the device. So you shouldn't take this compressor and this nebulizer, for example. That creates problems because they were designed to be used together. Also, some compressors deteriorate in their function over time. So the Pulmoaid, which I'm not sure what that one is, but the Pulmoaid, not very much. The inspirational lead study in this paper, not very much. But that these lines do not overlap, show that here they studied, I forget how many different compressors, but this is the performance of the nebulizer at week 0, week 6, week 12, week 18, week 24. I guess the point is here that over the course, 24 weeks would be, what, half a year roughly? So over that time, the performance of this compressor nebulizer formula or combination deteriorated quite a lot. So that might not be a good thing. So we don't, when we practice in the hospital, we usually just hook the nebulizer up to the flow meter. This isn't something we have to think about, but this is an issue for why a patient, for example, might get admitted to the emergency department because their compressor isn't working very well, so they're not getting their medication as they should.
So that's more of the function of the compressor, not the nebulizer?
Correct. So this is the function of this deterioration is the result of the compressor over time not being able to generate the same pressure and flow. So what about ultrasonic nebulizer? So this uses a piezoelectric crystal, in this case the transducer, that vibrates at a high frequency. That converts electrical energy, which is applied to the transducer, to sound energy. That sound is concentrated here on the surface of the liquid, and that produces the aerosol. And then there can either be a fan to blow the aerosol to the patient, or for devices such as these that the patient might use at home, which are handheld devices, not very large at all, the patient just breathes through the medication cup to get the aerosol. So these are handheld devices intended for home use to deliver aerosolized medications, which are actually ultrasonic nebulizers. And some of these have become quite popular in recent years, particularly because, as we'll touch on in a few minutes, meter dose inhalers have gotten extremely expensive. So this may be a cost-effective alternative, and this does not require a compressor. So I guess if I was a patient who needed one of these, and I had to choose between this or this, I'd take this. Much more portable, doesn't require, it's battery operated, doesn't require a compressor. There are also delivery systems such as this, specific delivery systems for specific medications. In this case, the Tyvaso inhalation system that uses the Optineb. This is an ultrasonic nebulizer. This comes from the manufacturer with the nebulizer, the ultrasonic nebulizer, and the drug as a combination. Usually comes from, I think they come from specialty pharmacies. This delivers inhaled pulmonary vasodilator, specifically treprostinil, and patients typically will use this 4 times a day, 3 inhalations with each session. I'm not sure if any of you have ever put your hands on one of these, but one of the complaints that patients and caregivers have about this system is there are a lot of pieces. So when you have to take it apart and clean it, there are a lot of different parts that have to come apart to clean and put back together again. So now let's turn our attention to mesh technology, another type of a jet nebulizer. This is the newest form of technology. You're familiar with this from the Aerogen Solo, which fits into the ventilator circuit or fits into high-flow nasal cannula system. With mesh technology, there is a membrane, and in that membrane are drilled, actually they're not drilled, but in that membrane there are a whole bunch of little tiny holes, thousands of little tiny holes, so small that you can't see it if you try to look at it with your eye, unless you have really, really good vision. But there are a whole bunch of little holes in that membrane, in that mesh. And then either the membrane vibrates back and forth to force the liquid through the mesh to produce the aerosol, or sometimes there is a vibrating horn which pushes the medication through the mesh, and in that way generates the aerosol. One of the important determinations of the aerosol particle size here will be the size of the holes in the mesh. So you could imagine that depending upon the formulation, the mesh might be different for one device than for another device. And we're going to get into that in just a minute. So some of these are specifically designed for a specific formulation of drug. These use no propellants or gas flow, so that's an advantage. They have virtually no dead volume if they operate correctly. So that's an advantage over a jet nebulizer. So the way that the mesh nebulizer is supposed to work is you put the solution in, and all of the solution is aerosolized to complete dryness inside of the device. Now, as I'll show you some data in a minute, that doesn't always happen. And it has a high output rate, so it doesn't take long to deliver the drug. So here are some examples on the slide, so you know the Aerogen Go, that's what goes into the ventilator circuit. That can also be configured for a spontaneously breathing patient using a valved holding chamber, which is called the Aerogen Ultra. So this is a holding chamber. The device aerosolizes the drug into the chamber, and then the patient breathes the drug out of the chamber. Patient exhales. There's a one-way valve here. They exhale out into the room. The Aerogen AeroNeb is also designed for home use. The Omron, which is a pretty popular nebulizer for home use. I don't know if you see this used, but it's pretty. It's because it's not very large, and it's very portable. It's battery operated. It uses mesh technology, similar to what the Aerogen does. And then the Pari eFlow is available in several different configurations, as we're going to see in a minute. Pari has taken a different approach than Aerogen. So Aerogen has taken the approach of having a generic nebulizer that could be used with any formulation. We put bronchodilators into it, we put antibiotics into it, and so forth. Pari has taken the approach of working specifically with drug companies to come up with specific formulations that match the nebulizer to the drug. And from what I just said, you can imagine that they might configure the holes in that membrane differently depending upon what the drug is to optimize the output. So this is one of the maybe dirty little secrets about the Aerogen, and I suspect that everybody in the room has encountered this, unless they got a lot better since I retired a few years ago. But that is that sometimes they just stop working. And that was reported in this study, published in Respiratory Care a couple of years ago now, where they show that sometimes they put the solution into the Aerogen, and they run it, and it runs to dryness here, like it's supposed to. Here, partway through the nebulization, it just stopped, for no apparent reason. I mean, this was in the lab, so you couldn't blame it on the nebulizer or the ventilator settings or the how fast the pump was running. It just stopped. And I'm sure you still get reports of that. I mean, I know a couple of years ago that used to be a safety report a week, you know, about a patient who was on aerosolized Voletri, and somebody comes into the room and the nebulizer is completely full and it's not delivering an aerosol. And I guess what I'm telling you is that's real. And in fact, it was demonstrated in this study. There are also now several eFlow device drug combinations that have just become available over the last 5 years or so. The first one is Caistin, a strand M, an inhaled aminoglycoside, which is coupled, the drug is coupled with the eFlow mesh nebulizer. This is the Altera system. And what the patient gets, I'm sure they still do, what the patient would get from a couple of years ago, they get a big cardboard box, and inside the box would be this aerosol delivery system, and a bunch of the dry powder drug and these little saline ampules. So then how it works is the drug, the casein, is reconstituted with the saline and then is squirted into the device. And the nebulization time is very short, 2 or 3 minutes. Patients take it 3 times a day, at least 4 hours apart. And similar to inhaled tobramycin, the patient takes it for a month and then they're a month off, and that's to reduce the risk of antibiotic resistance. It's recommended that patients are pre-treated with the bronchodilator. So there's one example of drug mesh nebulizer combination. So PARI, who makes the E-Flow, has been working with a lot of different companies. So this is one that just got released within the last year. This is the Linhala Magnar, which is aerosolite glycopyrrolate, which is a long-acting muscarinic antagonist. Here again, there's a drug-device combination, and how this works is that the glycopyrrolate is provided in these little vials. The little vial gets pushed into the medication, the nebulizer cap, the medication cap. Then it gets screwed into the device, and then the aerosol is delivered. So you can't use Linhala Magnar glycopyrrolate with any nebulizer other than with this nebulizer, because the drug and the nebulizer come as a combination. And another one, and there may be even more of them out there in the pipeline. So this is aerosolized liposomal amikacin. This just became available, I believe, the end of last year, last November or December. So this is for the treatment of Mycobacterium avian complex. Primarily, this is used in patients with cystic fibrosis who have nasty bugs that are not eradicated by usual antibiotic therapy. And this uses the Limera nebulizer, mesh nebulizer system. So as you can see, the folks at PARI who make the E-Flow have been busy working with drug companies to make sure that their nebulizer gets paired with these new drugs. And I don't know for sure, but I believe the implication is, but I have not had anybody been able to tell me, yes, that indeed is the fact. The implication is that the meshes in each of these devices are manufactured differently for that specific drug to optimize the output. Another type of mesh nebulizer is the iNeb, Adaptive Aerosol Delivery System. This is used to deliver iloprost for the treatment of pulmonary hypertension. Again, this is a mesh nebulizer. This gets used 6 to 9 times per day. And the clever thing about this nebulizer is that the patient puts the mouthpiece in their mouth. They begin breathing through the device. The device analyzes the patient's breathing pattern, and then it starts delivering the drug right at the very beginning of inhalation. So in other words, the part of inhalation which is going to deliver the medication most likely to the alveolar space of the lung. So that's clever. That's what you would want to treat pulmonary hypertension, for example. You wouldn't want the drug to deposit in airways. You'd want it to go to the alveolar space, and the adaptive aerosol delivery is intended to do that. And you may or may not be aware of the Respigard, which is used for pentamidine administration. Back in the late 80s, there were a lot of patients who received pentamidine for PCP prophylaxis, and then it was found that Bactrim works just as well, if not better. It's a lot easier to take a Bactrim orally than it is to use the Respigard device. This device is configured with a special nebulizer, valves, filters, and so forth to maximize the amount of aerosol delivery to the patient and to minimize the amount of aerosol that makes it out into the room. So then what I show on this slide is that now there are a number of nebulizers that are approved only to be used with a specific formulation of drug. And outside of bronchodilators, particularly outside of beta agonist bronchodilators, I think this is the kind of thing we're going to see increasingly in the future, is that new drugs will come out and they will be approved for use with only a specific nebulizer. So Toby, for example, only gets used with the PARP, and Dornase Alpha only gets used with a handful of different nebulizers. And I think all of these other ones we have already talked about, but I suspect that if I am not too old and come back and do this talk again in a couple of years, that I'll have to make the font size smaller, because I think there will be more drug device combinations which will get approved.
Maybe you can take the spag off.
I know, I was just saying, take that away.
Oh yeah, that's right. So that'll make room for another one. Yeah, I think the company has stopped manufacturing the spag. I don't think you can even buy it anymore.
Oh, well, they could buy one from us, maybe. We got all of them.
Get rid of them.
So that'll be, yeah, so I take the spag off, that'll make room for the other one that comes up.
What does this then do for healthcare costs? Right, so if I'm a patient and I'm taking 2 of these drugs.
Yeah.
So now I have to have 2 separate nebulizers, and what does that then do for the
Yeah, it makes it a lot.
confusion,
It
right?
makes
So we
it,
talk
it
about
makes
this all
it,
the time then.
it makes it more confusing.
Yeah.
And this is something, if I don't get to it today, we'll talk about it next time. It makes it more confusing for the patient because they have multiple devices and they forget which one does what and when to take it and so
They may
forth.
have multiple.
And it for sure drives up the cost of care.
Yeah.
So if you or a family member has cystic fibrosis, the cost of your care, particularly if you get on one of these new gene-altering oral medications, cost of the care can be $500,000 a year. And that's something that is being heavily debated, I think, by society now. And there are a lot of accusations of the drug companies who are taking advantage of sick people. And so, yeah, I think a year's supply of one of the new Vertex drugs that CF patients can take orally as a gene-modifying drug, and it works. It does good things. I think it costs like $350,000 a year. So it's it's. And while we're on that subject, and I was going to talk about it with meter dose inhalers, that has been a big problem with pressurized meter dose inhalers when they went from CFC Freon formulations to HFA formulations. All of the devices got repatented. So then all the generics went away. So then the companies could pretty much charge whatever the market could bear. And patients, all of a sudden, patients who were on generic albuterol, it cost them $10 a month for their drug. And some of them were having like $100 copays, and just for one drug. And you really have to question, what the real motivation of industry is.
I mean, I suppose if they're receiving a higher percentage of the drug, then perhaps it has better effect, and they're not in the hospital. They don't need all of that kind of stuff. But if not, then it seems.
So what's going to happen? What has already begun to happen is that these drugs are going off patent and generics are becoming available. So there's generic Toby now, and the MGH might use it. I was asked to weigh in on this by email like a year ago. They were thinking about changing to a generic. So has that happened?
But they're not doing the compounding here.
Okay.
They were going to do that.
But there are several generics of Toby.
Yeah.
Where the drug, I think, is like half as expensive. Still has to be used with a PARI nebulizer, but that helps. Furnace was telling me just an hour ago that the Strianam is coming out with a generic. So that'll decrease the cost of that. And there will be, it has been approved, I don't think it's yet available, there will be a generic HFA meter dose inhaler formulation available any day now at 50%, half of the cost of the HFAs that are out there now, the Venolins and the Proventols. And I think as more of these drugs come off of patent, and it's going to start happening pretty quickly because a patent is good for 20 years, and usually it's 10 years of development and then 10 years of marketing. And if you think about a lot of these drugs came out about 10 or 12 years ago, so they're going to be going on patent. But I think it's a big problem. And the cost of the inhaled medications is only a part of the bigger problem.
Like, we'll put we're forced to, like the tobramycin, to put it in the irritant.
Correct.
And nebulized, the patient gets some tobramycin. What is the difference? And could those differences, rather than having specific drugs, could they say, instead have like a just have adjust the dose to.
Yeah, so.
Because the big deal on using the specific one is that it's going to give the required dose.
Yeah, so all of the clinical trials of inhaled Toby were done with the PARI nebulizer. Now, if you use another nebulizer, maybe it's just as good, maybe it's better, maybe it's worse, but you're on your own.
Yeah.
Because it hasn't been studied. So I think in a ventilator circuit, there's no choice but to use a mesh nebulizer or standard jet nebulizer. What we don't know is, does that deliver less than we would get, which would be ineffective? Or the other side of that is, maybe it delivers a whole lot more and puts the patient at risk for aminoglycoside toxicity.
Right, so you could have like a normal recommendation. If you're using this net, this is the dose.
Yeah, but it has to be studied.
Yeah,
And
and this has been a problem for several years.
Oh, yeah.
And these studies are not hard to do on the bench. You do it on the bench, right?
That would be the first step.
Yeah.
Yeah, the first step would be to do it on the bench and then to confirm that in patients. But I give you.
But all you're measuring, the variable is the output. The output you don't
Correct.
need a patient to measure.
So you could convince me. I don't know if you would convince the FDA. So I'll give you an example. So there was a patient in the RACU about 10 years ago who had a nasty gram-negative bug in her lungs, and the attending in the RACU at the time wanted to try inhaled Aerosol, but the patient was on a ventilator with a trach. So I can recall we brought a nebulizer in here, we plugged it in right behind Kevin, we took the Aerosol and we dumped it into the mesh nebulizer instead of dumping it into the Altera nebulizer, and we looked at it and it made an aerosol. So we said, well, it's doing something. What do you think? And the attending from the RACU came down and she looked at it and she said, I think we'll try it. And so they started the patient on Aerosol by mesh nebulizer through the ventilator, and a few days later, the patient's renal function studies spiked. So not only did it work, it really worked. So the good news was that it actually cleared up the patient's infection. The bad news was that maybe half of the dose would have worked just as well and would not have. Now the patient's renal function stopped the drug and get back to normal and so forth. So that's the thing. You don't know if you substitute a different device, will it not work as well, or will it work the same, or will it work too good? And I think we often tend to think that more is better, but maybe more is not better. Okay, so we have 15 more minutes, so let's continue. And then we're going to have time for another in-service. So a device that became available, I believe about 10 years ago, is the Respimat device. It might have been available for a little bit longer than that, but not much more. So here you can see a schematic of the device. The device produces a very fine, soft mist. So the benefit of that is that there's less pharyngeal deposition than you get with a meter dose inhaler, for example. There's no propellant, there's no compressor, so we don't have to worry about the propellant and what it does to the atmosphere, or the compressor and electrical power source and so forth. It has a dose counter, so that's a good thing, you know, when it's empty. Typically, the device has enough medication for 1 month, so generally these are good for a month. So the dose counter will vary by device depending upon whether you use it 4 times a day or whether you use it 1 time a day or 2 times a day. And the energy to produce the aerosol comes from a spring within the device. So how it works is you twist the base, that compresses the spring, and then you press the button, and that releases the aerosol. So the patient turns it, puts it in their mouth, begins to breathe in, presses the button, and gets the drug. You have many patients that use this?
We have a fair amount. Spiriva
For,
just came out. with
so
it.
Combivent is the, for a while, this is the only way.
Yeah.
The way you can get, the only inhaler for Combivent, or you could use it doing that nebulizer. And now tiotrophins by Riva is available in this device as well, which I always thought the hand inhaler was kind of clunky, so maybe this is a little bit better. So, and in fact, Boehringer Ingelheim is the manufacturer, and now they have a whole family of inhalers. So they have a short-acting beta agonist, short-acting muscarinic antagonist. This is only available in Europe, so we can't get it here. But Combivent is available in a Respimat, and you confirmed what I thought, what was my suspicion is that it's pretty popular for patients with COPD, so this would be a COPD drug. Spiriva, which is now available by the Respimat, so tiotropium, long-acting beta agonist. And then there are several others, long-acting, Spiriva's long-acting muscarinic antagonist. There are now several others that just became available. One is a long-acting beta agonist. This is available in the United States. And a combination long-acting muscarinic antagonist, long-acting beta agonist. And this is something that would be used. This would be a COPD drug. This could be COPD or asthma. This is COPD drug. So.
Yeah, I'll make it 2 doses in the Spiriva.
How's that?
They make it 2 doses in the Spiriva.
Oh,
I
okay.
forget if it's green or blue. One of them is 100 and one's
Yeah,
250, so one is for COPD and one's for asthma.
Oh, okay. Good. So the lower dose is probably for asthma, I would guess. Yeah, because only recently have long-acting muscarinic antagonists got into the guidelines, the GINA guidelines for asthma. Good. Well, I'm glad you came. So I learned something. We all learned something. Okay, so a few things about meter dose inhalers. So here's a schematic of a pressurized meter dose inhaler that all of you are familiar with. Notice that for the pressurized meter dose inhaler, the amount deposited in the lungs is really not any different than what we get with a nebulizer. So with a nebulizer, we said most of the drug gets wasted. So it gets aerosolized or exhalations trapped in the device. Where does the other 80 to 90% go with a pressurized meter dose inhaler? In the oropharynx.
Yeah.
So a lot of the dose gets deposited in the upper airway, and the deposition can be decreased if the patient does not use good technique, as you know, so the deposition will be zero. The patient's blowing out in the device while they're actuating it. So this gets back to something that I already mentioned a few times already. So by 10 years ago, it was determined that there would no longer be CFC, chlorofluorocarbon, or freon propellants in meter dose inhalers. That was all changed over to HFAs, hydrofluoroalkanes. As a result of that, all of the manufacturers had to redesign their meter dose inhalers. So it wasn't just a matter of taking one out and putting the other in, because they learned things such as when they did that, it changed the particle size, it changed the amount of drug that was emitted and so forth, so they had to retool the whole thing. So then what did the manufacturers do? Well, they patented that new technology, and then the cost of meter dose inhalers became exorbitant. There was just a story in the Boston Globe about a month ago of a person who, an elderly person with COPD who had to stop taking their inhalers because they just couldn't afford the copays anymore. I was, remember probably 5 or 6 years ago, I was on an airplane flying somewhere, and there was a woman sitting behind me. It could have been a man, but it happened to be a woman sitting behind me and talking real loud and telling the person in the seat next to her that she doesn't know what she's going to do because her son has asthma, and the cost of his medications went from like $10 a month to $150 a month. So there are all kinds of stories like that that are true. And this gets back to the point that Carolyn had brought up. So the good news is that that might start getting better, because those devices are all beginning to go off patent, and generics are becoming available. And the first one was just recently cleared by the FDA, and they're advertising that the cost will be 50% of like a Provental or a Ventolin. And as more generics become available, hopefully the price will continue to come down.
Dean, can I add something there, especially with the clogging actuator?
Right.
ProAir, I was on ProAir, which is a generic, and it's the red one, and I was having a hard time, and it's not working, and I know I just bought it last week. So I brought it right to the pharmacy. I said, this is not working. There's nothing coming out. She goes, is it clean? I'm like, of course it's clean.
Were you ever embarrassed?
Oh my God, I was horrified. So she took it, ran it under hot water, and just for us to know that, right, the red ProAir. Now, and the Ventolin, the blue one, I never have a problem with it. And that's not generic, so I don't know if the generic has something else in it that clogs it more. But with your asthma patients, and they have their medicine, they've been taking it, just go and test it, because it's probably just clogged. Yeah. And once a week, you have to really run it under hot water and make sure.
Right as shown here.
Yeah. Oh, you're showing. I'm so sorry. I didn't mean to interrupt you.
That was my next slide, but good segue.
I didn't mean to do that. Yeah, okay, great. That was so frustrating.
Yeah, so with the new, one of the issues with the HFA formulations is that the actuator can clog. And as
but it's funny how the generic it does, but on the other one it doesn't. On the Ventolin it didn't.
Yeah, well, but at any rate, but what's recommended now is that they get cleaned out, rinsed, and dried overnight. And evidently, the Advair HFA is the worst. And that one you even have to take a cotton swab, like a Q-tip, and clean it out real good and so forth. So you are correct, Patty. So one of the problems with the HFA formulations is they tend to clog. So that's something we need to be aware of. So dose counting is important so that the patient knows when their device is empty. And you can't just go by, shake it up, and does any aerosol come out? Because the aerosol may be, if the inhaler is near empty, the aerosol may just be propellant, no drug at all. So patients need to know when their device is empty. This is a study, not that old, 10 years old, found that a quarter of patients, their inhaler was empty when they had an attack, and that can lead to ED admissions. Flotation methods, just don't go there. So we used to, I used to teach patients to get pan water, put the inhaler in the water. I think the first asthma guide that we had might have even had a picture of that on the bottom, and then like this, and then like this. But not in my book. So just don't even go there. So you just need to keep track of the number of doses. I know we used to tell patients, well, it's a good idea every time you use it, keep a card and, tick off how many. Nobody does that. That's a really compulsive individual who does that. So what you need is a device that has a dose counter. And now, most of the devices do. My grandson uses ProAir, and I know his ProAir has a dose counter on it now. And so almost all of them do. There are add-on devices like the doser that can be used, but that adds some expense, and I believe that virtually every inhaler that's out there now has a dose counter. Of course, that doesn't help you if you are using a meter dose inhaler in a ventilator circuit, which
Oh, no,
don't do much anymore, but
It does
Yes.
work
Yeah.
now. We got the
Oh, does
new
it?
adapters.
oh, okay.
Yeah.
Because it used to be that the dose counter was in the mouthpiece actuator.
And they would break it off.
Yeah. Yep. So another thing that is not as well appreciated as maybe it should be is that so it's important to only use the device for the labeled number of actuations. It's also important to appreciate that a brand new inhaler needs to be primed with several actuations where you shake it up and you blow it out into the room. So the first couple of doses are variable to nil. And the priming requirements vary according to the device. There are none that are more than 4. So if you just always did 4, you would waste a little bit with some of them. I'm looking here. So what is it for the Pro Air, Patty?
I can't see.
It's not on here. I just so you don't even need your glasses.
So and each one of those.
I'm going to guess it's probably the same as the other albuterol, but I don't know. I just realized Pro Air's not on there.
So it has 105 doses, you're going to sit back.
Correct. Yeah. So you would, or if it has 200, so 200 actuations, I think is typically what is in the inhalers that patients use at home. So every time they prime it, it counts down. So those are fewer doses that are available.
So that's,
I'm hosting it.
and if it's, say it's a PRN, you only
Yeah.
use it every 3 weeks. each
Yep.
time you
So
use it-
Kevin brings up a good point. So it needs to be primed when it's brand new. Also needs to be primed if it has not been used for a while.
Or if it's
And
dry.
I say a while in kind of a nebulous, no pun intended, way.
It says
Because I don't know. I think certainly if it hasn't been used for 3 weeks, your example, you have to prime it again.
the fluticasone says that you have to reprime it if you drop the meter dose inhaler also.
Oh, okay.
Yeah, it was news to me till I read it on the.
I guess that makes sense. I did not know that, but I guess that makes sense because if you drop it, it could result in the dose, which is in the metering chamber, being jarred back into the canister. So you have to reload. So what the priming is doing is it's loading. So the priming is what the priming is doing is it is loading this metering chamber. So the priming is clearing out whatever propellant and loading that so you get a consistent dose. So I can imagine if you dropped it, that particularly if you dropped it with canister first, then you could jar the medication potentially out of the metering chamber. So I guess there the advice is don't drop it. Okay, so that's probably a good place to stop. So next time, you'll have to think about how I package this for the next time. So the next time, maybe what I'll do is I'll review a little bit on the medications and I'll review a little bit of the high points on the devices we've talked about so far.